So my name is Tara Schmidlen. I am the genetic counselor for the Coriell Personalized Medicine Collaborative Study. So I'm going to talk to you a little bit more about your CPMC results and what we commented on in our results specifically. Okay, so first we're going to talk about the genetic versus environmental contributions to pancreatic cancer. Then I'll talk a little bit more about the 3 genetic variants that we looked at for your genetic variant risk. And then I will actually talk a little bit about the limitations of our testing and then go through some resources for more information that are available to you through the study. Okay, so this scale image should look familiar to you. It's actually copied from your results. So one of the things that we want to get across to you is how much of pancreatic cancer is thought to be due to genetic contributions or genetic variants like the ones that we looked at in the study, and how much of it is thought to be influenced by environmental factors or lifestyle factors or things like whether or not you smoke or whether or not your body mass index, whether or not you're obese or overweight. So about 64% of pancreatic cancer is actually influenced by those non-genetic factors. So things like being a smoker, having high alcohol intake, having a high body mass index. About 36% of pancreatic cancer is actually influenced by different genetic variants like the ones that we tested for in the personalized medicine study. So the colored balls in this basket are really just representing that there's several genetic variants that make up this 36%. We only looked at 3 genetic variants in the study for your particular report, but there's many more than 3. And in addition to there being more than 3, there's genetic variants that have varying levels of influence on the risk for pancreatic cancer. So some of them are playing a very small role, others are playing a much more significant role, but maybe much more rare in the population. That brings me to the next scale image. So there are genetic variants that are rare in the population that we do not look for in the personalized medicine study, that are associated with an increased risk for pancreatic cancer. And in those cases and in those individuals, that genetic influence over pancreatic cancer would be much more significant than the non-genetic risk factors. So one example of genes that most people are probably familiar with are the BRCA1 and 2 genes that we commonly hear about in the context of breast and ovarian cancer. Families that have BRCA1 and 2 mutations are actually also slightly increased risk for pancreatic cancer as well. So there's a number of other cancers that come along with the BRCA1 and 2 genes, pancreatic cancer being one of them. So on the previous slide, I mentioned that there are several sort of balls in that genetic risk bucket. And to be more specific about that, there's actually been 405 genetic variants that have been identified in the medical literature to be associated with pancreatic neoplasms. Now, not all 405 of these variants have been seen in multiple studies or in multiple populations, but this is just to give you an idea of how many there have been identified at some point in time. Now, the Coriell Personalized Medicine Study, when we select the variants that we're going to report back to you, we choose variants that have been seen in multiple studies, large studies, so we're talking thousands of individuals, and we're also looking for them to be in different populations as much as possible too. So ideally we want to see them in Caucasian population and African American or Asian population as well. So this slide is really just to kind of drive home the point that your particular report from the Coriell Personalized Medicine Study commented on your risk due to 3 genetic variants, but there are, at least at this point in time, over 400 that have been identified, and there's likely others that haven't been identified yet. So the analogy that I like to use is it's a bit like having maybe 3 pieces of a 500-piece puzzle potentially. So you have some idea of what that risk picture is, but you don't have the whole story. So this slide is talking about sort of the genetics of cancer risk in general. So, and I've already kind of alluded to this, that the personalized medicine study looks at genetic variants that are common in the population. So lots of people have these variants, but they're also what is called, or what is known as low penetrance variants. So the concept of penetrance really refers to if you have a genetic variant or genetic change, what is the likelihood that that variant or change is going to manifest in the disease or the condition that it's associated with? So the variants that the study looks at are by nature low penetrance. They're very common in the population, but they're also low penetrance, meaning if you have that genetic variant, it's not 100% likelihood that you're going to develop the disease. In fact, it's probably nowhere near that. So So these three numbers, the RS numbers, are just the scientific numbers for the variants that we looked at, and they were the ones included on your report. So as you can see, they're much more common in the population and their relative risk is much lower. But when we move towards more rare variants, the penetrance goes up. They are a little bit more involved in actually producing disease. And when we get to the even more rare variants, things like the BRCA1 and 2 variants that I mentioned before, those variants are rare, so not many people in the population have them. For instance, BRCA1 and 2, about 1 in 500 in the Caucasian population will have a mutation in BRCA1 or 2, which is not nearly as common as the variants over here, where maybe 30 to 40 out of 100 will have the variant. So for the rare variants, you know, they're rare, but they're higher penetrance, so they're much more likely to produce disease when they are present. And that's partly because these variants are occurring in genes that are maybe tumor suppressor genes, like the BRCA1 and 2 genes, where they're playing a much more substantial role in the development of cancer than the variants that we looked at in our study. So is pancreatic cancer genetic? So when we're talking about the more rare genetic variants, about 10% of pancreatic cancer cases are going to be due to rare hereditary cancer syndromes, or those rare genes that we're not actually looking for in the personalized medicine study. We do want to make sure that people are aware of some of the red flags that we use to determine who might have a family history that is suggestive of one of these rare syndromes. So anytime we see cancers occurring before the age of 50, early onset cancers in anyone, or anytime we see 2 or more family members with pancreatic cancer or a related cancer diagnosed at any age. So related cancers might be things like colon cancers, breast or ovarian cancers, things that would go along with BRCA1 or 2. There's a familial melanoma syndrome that has some pancreatic cancer associated with it. And there's a couple other more rare syndromes that involve pancreatic cancers. Multiple primary cancers in one person, so somebody being diagnosed first with one cancer, like a breast cancer, and then later on with another type of cancer, a pancreatic or an ovarian. We're looking at clusters of affected relatives. So, you know, maybe mom had a cancer and then her sister also had a cancer and then that sister's daughter. So anytime we see clusters of affected family members and cancers occurring across multiple generations, and also rare tumor types. Those are some of the common sort of red flags that we look for when we're trying to decide who might have a cancer that might be due to one of these more rare genetic variants, as opposed to the more common variants that we look at in our study. So I encourage individuals who have family history that sort of meets any of these red flags. I do encourage you to contact me. I'm happy to go over family history. I know for some of our participants have joined the study and have been in the study for over 5 years now, and certainly family history has probably changed in that time frame. So anyone who's had family history that sort of matches this, I encourage you to contact a genetic counselor. You can actually do that through your results, and I'll show you how to do that later. I can actually sort of review your family history, see if you meet the criteria, and then would refer you on to what's called a cancer genetic counselor, which is a genetic counselor who focuses on hereditary cancers and would be able to work with a physician like Dr. Adebeck or any of the other physicians in the local area to actually order testing potentially, or to sort of manage your risk differently than we would for somebody with a lower risk for cancers. So for the particular variants that we actually looked for on the CPMC study, we actually give you a summary of them. Again, we tested for 3 genetic variants. One of those variants was a protective variant, so if you had 2 copies of the G allele, that was considered protective and gave you a little bit lower risk for developing pancreatic cancer. The other 2 variants were actually risk variants, meaning that if you had the risk allele, that actually increased your risk slightly for pancreatic cancer. So what we looked at was the combination of the 3 and determined your risk from there compared to the genetic risk of an average risk individual. And this information is all available on the About Genetic Variant tab of your result, so that you can see what genes they were in. This RS number is, if you were going to Google anything, this is the number you would Google. This is the scientific name for the genetic variant. And then this is just where in the genome the variants are located. This slide just gives you sort of a little bit more detail on each of these variants. So the first one was the protective variant that was in the NR5A2 gene. This gene is thought to play a role in cholesterol and bile acid regulation, and also the generation of steroids from cholesterol and cell proliferation. The other two are the risk variants. The CLPTM1L gene is associated with an increased risk of pancreatic cancer, and it's thought to play a role in what's called apoptosis, or programmed cell death. And then this last variant, the last risk variant, is the KLF5 and KLF12 genes. This one is associated with increased risk, and it's thought to regulate the expression of some other genes that are involved in the development of cancers and the transformation of normal cells into cancer cells. So we do know a little bit about the function of these genetic variants. You should recognize this image from your results as well. So this image is just trying to give you a sense of, based on the 3 genetic variants that you have, you were put into a risk category, either decreased risk, average risk, or increased risk, and that was compared to the risk of an average individual. What did your 3 genetic variants tell us about your risk? So this image really here is just to give you a sense of how many people fall into each category if we were to test 100 people. So about 80 and 100 people would fall into this average risk category. About 8 and 100 people would fall into the increased risk category based on these 3 genetic variants, and then about 12 and 100 people would be falling into the decreased risk category. And this data is actually based on the Caucasian population. That's where we have the most data and the most literature for. This slide is actually just a screen capture of the risk summary slide from a sample risk result. So for this particular individual, was that average risk for their genetic variant score. So this should look very similar to every other result that you've received from us in the study. However, this time this green disc, instead of representing just 1 genetic variant, it represents your risk from the 3 genetic variants that we were just talking about. So this risk summary is really just showing you the factors that we give you risk information for, which for the pancreatic cancer report was the 3 genetic variants represented by this green disc, your family history risk represented by the purple disc, and your smoking status and your body mass index. So just as a reminder, we cannot combine these risk scores and sort of give you a final risk score. We don't have a way of doing that yet. Were we to follow all of our study participants in time forward 30, 40, 50 years and look at who had the 3 genetic variants, a certain combination of the 3 variants, maybe a certain family history and the smoking status and body mass index, we might actually be able to answer that question, but we don't have that data now. We don't have the ability to combine accurately these risk scores into one risk score at this point in time. So this is just a zoomed up closer up look at the genetic variant risks tab on a particular result. So you will find your result interpretation, which actually gives you your relative risk value on this your result interpretation tab. So for this particular individual, they actually did have an increased risk, and their relative risk is 1.44. So the interpretation says, based on your combination of genetic variants, you're 44% more likely to develop pancreatic cancer than an average individual. Now keep in mind, this is based on only 3 sites of genetic variant in those 3 genes. And as we said at the beginning of this, we know that there's over 400 that have been identified at some point in time. So this risk is elevated compared to an average risk individual. However, what might happen is if we were to go forward in the study 5, 10 years, and let's say we added 10 or more genetic variants that we've now discovered are also very highly associated with pancreatic cancer, that person's risk may change. So you might end up having maybe 5 variants that are protective, that you had 2 copies of the protective variant, or you might have 4 or 5 that you have an increased risk for, that you have 2 copies of the risk variant. So this relative risk is based only on those 3 genetic variants, and it's something that could change if we were to look at additional genetic variants in the future. So like I said before, it's like having 3 pieces of a 500-piece puzzle, and as you can imagine, if you were putting together a puzzle and if you only had 3 pieces, you wouldn't have much of an idea of what that big picture risk is. You would have some idea, but you wouldn't have the whole story. So that's kind of how to think about these genetic variant results, is that you have some piece of the risk, the greater picture of the risk, but you don't have the whole story. So the next result tab that you would see on your report would be for family history, and that's represented by the purple disc. And family history is actually still the best risk predictive tool that we have. And the reason that family history is the best risk predictive tool that we have is because family history takes into account all of the genetic variants that we know about and that we're able to test for, all of the ones that we don't know about yet, the ones that haven't been discovered, and it also takes into account the shared environment and lifestyle and behavioral factors that we have with our families. So for instance, if you grew up in a household where everyone smoked, you may have been more likely to become a smoker yourself. If you grew up in a household where exercise was a priority and every night after dinner your family went for a walk or on a bike ride together, that might be a behavior that you carried forward into your adult life. So when we're looking at relative risk data for family history, we're really getting a sense of the risks that encompasses both the genetic and both the environmental and lifestyle factors. So for our particular results, we looked at whether or not you reported a family history among your first-degree relatives. So first-degree relatives are parents, siblings, and children. So if any parent, sibling, or child had pancreatic cancer, that would increase the risk, the relative risk for pancreatic cancer of an individual to 1.8, or make you 80% more likely to develop pancreatic cancer just for having at least one first-degree relative. As Dr. Atterbeck talked about, body mass index or being overweight is associated with an increased risk for pancreatic cancer. And this particular individual, or this sample result, this person had a body mass index between 25 and 29. So 25 or lower is considered normal, healthy range. Between 25 and 29 is considered overweight, and over 29.9 or BMI of 30 or greater is considered obese. Just for your reference. So for this individual, they were overweight, and as a result, they're 20% more likely to develop pancreatic cancer compared to someone whose body mass index is in that normal range. If you are obese or have a body mass index of 30 or greater, the relative risk is 1.5, making you about 50% more likely. And this is based on a single study or on multiple studies. And the studies that we base our relative risk data on are actually listed on the methods tab of your report if you're interested in looking at the actual literature that we pulled the information from. So that's always available to you. Smoking is also a risk factor for pancreatic cancer, as we mentioned. This particular individual is a current smoker, and as a result is 70% more likely to develop pancreatic cancer compared to former and never smokers. So not a surprise here. Smoking's been associated with a lot of conditions and has been included on a number of our reports. So I don't think anyone's surprised to see that. Just sort of for your reference, a former smoker, someone who quit less than 10 years ago or has quit within the last 10 years, their risk is a little bit lower at 1.5 or 50% more likely. And a former smoker who quit greater than 10 years ago, their risk actually goes back down to the average. So, some limitations of our results. And I've said this a number of times already, but there are variants in several genes that have been associated with pancreatic cancer. We have only looked at 3 in this particular study. No single genetic variant or even group of genetic variants is going to be able to completely predict your risk at this point in time. There are rare variants that exist that are associated with a high risk of pancreatic cancer, things like BRCA1 and 2 that I had mentioned before. The Coriell Personalized Medicine Study does not test for these rare genetic variants. They are not part of the research realm at this point in time. The clinical utility of testing for those rare variants has been established, and there are testing protocols and approaches to manage those patients. So that's why we aren't looking at that. We know what to do with that information. We know that it's useful to test people for those particular genetic variants. So results of CPMC testing alone are not going to be able to diagnose pancreatic cancer, and certainly if you got an average risk, it doesn't rule out the chance that you could develop pancreatic cancer in your lifetime. So a number of people will get an average risk based on the 3 variants that we looked at, but that does not mean that you're in the clear. It does not mean that you have no risk for pancreatic cancer. It just means that your risk is average based on those 3 variants. And as I said, if we were to look at additional variants going forward in the study, which we would likely do, people's risk categorization may change depending on the variants. Other risk factors, like your family history or your lifestyle, may have a greater impact on your risk than any individual genetic variant, which I think you've seen to be true based on the family history risk, the smoking risk, and the body mass index risk. As we learn more, your estimated genetic risk for pancreatic cancer may change. And it's something that we will likely do in the study. We will likely go back to a lot of the conditions that we've reported on already and look at additional genetic variants as the study goes forward in time. So it's possible that your risk may actually change as we are able to learn and know more about the genetics of these conditions. So I had mentioned earlier on your reports, on every single report that you get from the study, there's a tab called What Do I Do Now? And many of you probably found that tab if you found the information for tonight's seminar. That's where we always list any upcoming educational events and the details for that and the registration link. The other thing that's on that tab, that's always on that tab, is a button that you can click to email a question to myself, the CPMC genetic counselor. You can also click this button here that's to schedule an appointment to talk to me over the phone about your results. Or this button here in the middle will actually take you to a YouTube video or a web page where you can read more information about the condition in general, just to educate yourself a little bit more. And I will stress and highlight again, if you think you're at risk for a hereditary cancer syndrome based on the family history red flags that we went over earlier, please contact me and I'll be happy to discuss your risks, review your family history, and provide you with a referral for further evaluation if that would be appropriate. We have a lot of information on our website that I'd like to point out and sort of remind people. So when you go to the CPMC homepage, there's a genetic education tab right here. We have under that genetic education tab a number of web pages that sort of go over genetics 101 and basic concepts in genetics. We also have with the health conditions and drug response. If you click on this, you'll actually get a list of all of the conditions we've reported on so far in the study and the various web pages and videos that describe them in more detail. So I encourage people to take advantage of that resource. The other thing that appears under that list is a list of coming soon conditions for the study. So our next up report in May will be, oh my gosh, am I blanking on this one? We are going to report osteoarthritis risk in May, and then in June we're going to be reporting drug response for celecoxib, which is a pain medication that's actually often prescribed for individuals with arthritis as well as other conditions. So that information, you can always check our Coming Soon page to sort of see what other conditions that the study has been approved to report back to participants. Another thing that I want to remind you that's very, very important to the mission and the goal of our research is to complete your outcome surveys. So 3 months after you view your CPMC results, you will get a questionnaire dropped into your account, which you can find by clicking on the My Questionnaires button after you log in to your account. And these questionnaires they take about 5 to 7 minutes to complete, and they ask you some questions about what you did with your results. They ask you a little bit about what you remember about your results. They ask you if you shared them with your doctor, if you shared them with family members, if you made any lifestyle or behavioral changes, if you talked to your doctor about them, and if you talked to your doctor, did they recommend anything, or did you have a conversation, how did that go? Even if you did absolutely nothing with your results and you thought they were totally pointless and worthless to you, we still want to know that too. So please take a couple minutes to complete these questionnaires. They are incredibly valuable to the mission of our study. This is how we know what this information is doing for you. It's how we know if participants in this study are benefiting from having this information. It's how we know how physicians are interacting with this information. So it's very, very important. We also, as an added perk, will put your name in a drawing for an Amazon gift card. So there's a little more incentive to try and complete that. So for the first 500 people, we do a drawing for an Amazon gift card. So please, please, please complete your surveys and let us know what you're doing with this information. Thank you for your attention, and I will take any questions